Okay, we are going to get started here again with our last panel discussion before lunch. And I would like to remind you that at the lunch hour, we will have our young investigator presentations. So please eat your lunch back in this room. I think we'll give you one more reminder before lunch actually starts, but it's going to be a great session where we get to learn from some of our young investigators. Without further ado, I would like to introduce Dr. Sharma, who will moderate the soft tissue tumors panel.
Okay, well, thank you guys very much. I'd like to start just by thanking the Focused Ultrasound Foundation for organizing this session on soft tissue tumors. I encourage you to submit any questions online or come up to the microphones afterwards. And I think we have a great panel today with expertise that ranges from body MRI applications to MSK applications. We have a pediatric oncologist here. We have a surgical oncologist joining us remotely as well. And with that, I'll just move on to the next slide so I can introduce the panel quickly. Okay, so joining us from UCSF is Matt Buckner, who's going to be remote, and his area and experience is in desmoid tumors and sarcoma. Matt is performing clinical trials that are going to help us understand how to improve immune responses in sarcoma when coupled with focused ultrasound. Dr. Dengel is a surgical oncologist from the University of Virginia, and her expertise is in breast and melanoma, but she'll be talking to us about her clinical trial aimed to improve the tumor microenvironment and when coupled with immunotherapy and focused ultrasound. My colleague, Dr. Kim, is our pediatric oncologist here locally at Children's National. Her expertise is not only in pediatric solid tumors, but creating and running early phase clinical trials. And her trials that she'll share with us are aimed at improving treatment for refractory bone and soft tissue tumors, both with ablation as well as with hyperthermia enhanced drug delivery. And lastly, we have Dr. Ganouni here, who I don't think needs a large introduction, but he is an MR body radiologist, very interventional as well at Stanford, and he runs the very busy clinical focused ultrasound at Stanford as well. He's been involved with many pioneering trials and has a wide range from bone to brain to prostate, fibroids, soft tissue as well. So with that introduction, we're going to go to each panelist and have them talk for a few minutes about their work, and then we'll sort of come back to some burning questions. But before that, I'm just going to give you a little bit of background and context. So I think that we should talk about soft tissue tumors in the context of all of the other applications that we are learning about at this meeting. We have a relatively large experience in desmoid tumors. On the left are two images, actually from the first one from Dr. Ganouni and the second one, I think, from both Dr. Ganouni and Dr. Buckner, of two desmoid patients who responded very well to focused ultrasound treatment, and these were very good success stories. There are some limitations, which we'll come to at the end of the talk, with very large desmoid tumors that we want to address. And I'd encourage you to look at the abstract actually presented by Dr. Dukes, who was on the previous panel here, which talks about their very large multi-institutional experience with desmoid tumors. Then I thought I would put the next two figures in place to provide some context that these publications are really a decade old, more than a decade old. These are papers from 2010 that dealt mainly with sarcoma, both osteosarcoma, but if you look closely, there are patients with chondrosarcoma, Ewing sarcoma, and fibrous histiocytoma. And these, we have to realize, may have come a little bit before their time. There were also some concerns about whether the patients were offered focused ultrasound prior to standard care at the time. But what's important is that in 2010, or prior to 2010 actually, a lot of work was being done and showed some promising results. And I would like to put that in the context of everything we've heard at this meeting with the improved technology, the immunotherapy, the combined sort of trials with enhanced drug delivery, hyperthermia, histotrypsy, et cetera. And I think we can actually start making an educated approach to treating these tumors. I put osteosarcoma and sarcoma in both. This is a soft tissue tumor talk, but in the realm that Dr. Kim and I work, which is pediatrics, these are often very much the same, and they're soft tissue components of osteosarcoma and osseous components of soft tissue tumors. And even this morning, when I was listening during the thyroid ablation presentation, there was a case of a nodule which contained a central macrocalcification. So I think there are some lessons to be learned from other applications, certainly, that will help with soft tissue tumor treatment. The other thing that was apparent is that we both need to improve the safety margin and prevent skin burns. And the last, a little bit more recent paper from 2019 is from China that talks about recurrent unresectable soft tissue sarcomas. And really, that's the realm in which we're working right now with HIFU. So we'll move on to what is currently being treated. Well, a lot of things are being treated, and we've heard about all of these applications during this week. But what's kind of stood out in my mind is that the lessons that we're learning in several other applications are going to benefit our future treatment of soft tissue tumors, and vice versa. The stuff that we're working on in soft tissue sarcomas will be applied to other applications as well. And I just want to highlight some of the more, to me anyway, exciting abstracts that have been presented. A lot of these are in the veterinary section, and the lessons and the experience we're gaining from our animal patients in both canine and feline, I think are going to help us sort of move forward with our human trials. There are also other abstracts that I would like to highlight that I think can help us address some challenges with soft tissue tumors, including the beam shaping work that was presented, including the histotrypsy and checkpoint trial that's coming up, as well as Dr. Gruhl's fractionated hyperthermia, which is really being developed for the pancreas, but I think will also be applicable for our work as well. So with that, I'm going to stop for a minute, and Dr. Buckner will be presenting his work. Thank you.
Yeah, thank you very much for the kind introduction, and thanks to the Focused Ultrasound Foundation for the opportunity to be with you here today. This is one of my favorite topics to discuss. I'm actually at a conference in Barcelona talking about the same topic. I would say that my clinical experience is with focused ultrasound is dominated by my experience treating patients with soft tissue tumors, particularly desmoid tumors. That's more than half of the treatments that I've done as a faculty member at UCSF. And when I start to think about the technical needs and the conundrums for patients with soft tissue tumors, the difficulties that we encounter treating them with focused ultrasound, it's really, in some ways, it's dominated by my experience treating patients for other conditions. So, for example, top of mind would be the experience of treating patients with osteoid osteitis with focused ultrasound. So osteoid osteitis, those are small benign bone tumors. And the level of confidence that we have treating those patients with focused ultrasound is excellent. I know exactly which kinds of technical parameters to use and how many sonications are likely going to be required to effectively treat the patient. I therefore know how long it will take and what the patient's recovery is going to look like. I have really just an extraordinary level of confidence, but with many soft tissue tumors, I may have patients who respond incredibly well to the treatment and patients who don't have durable responses. I have patients with less pain after the treatments, patients with more pain after the treatments. And, I really don't know the reasons why. I don't have the answers to those questions. I feel like part of the reason for that is that these tumors tend to be much larger and, they're heterogeneous both within and across disease types. And that means that there are many more options for how we can consider treating them. They're going to inherently require more sonications to treat. And because of the variability and how we might design the treatment plan for these patients, I feel like even just within my own clinical experience over time, I've seen a lot of changes in how I approach these patients. How I treat them today is different from how I was treating them 2 years ago, and 2 years ago was different from 2 years before then. So I think about the needs and the research aims of my team at UCSF, and really our intentions are dominated by the desire to just get to a much higher level of precision and confidence, the same kind of confidence that we have when treating lesions like osteoid osteomas. And so that, for example, includes the ongoing trial of preoperative focused ultrasound that we have for undifferentiated pleomorphic sarcoma. Of course, we have this strong inkling based on lots of great basic science data that focused ultrasound may produce clinically significant immune response effects in these patients with UPS. And we are really hopeful that by doing some of the preliminary work right now, we can pave the way for future trials where we will be able to compare focused ultrasound combined with medications like immunotherapies and compare that to more standard regimens and see if we might be able to improve patient outcomes. So I think that's just a little bit of an overview of what I'm up to at UCSF. And again, I'm really excited to be part of this panel here today.
Thanks, Matt. Next, we have Dr. Dangle from UVA. Thank you, Lynn.
Good morning. That was a great lead-in to the work that we are doing at UVA, and I want to thank the Focus Ultrasound. We had a great pre-panel conversation, so I'm sure this will be a great discussion. And to thank my colleagues at UVA, which really built the foundation for the work that I'm doing now with Craig Slingloff and Tim Bullock and other collaborators looking at using Focus Ultrasound really in its immune sense. So I come at this more from a surgical oncologist perspective, and we've obviously had great success with checkpoint blockade and immune therapy and melanoma, but we still have a significant portion of patients who do not respond or have a delayed response. And so in trying to understand the different mechanisms we can use to alter the tumor microenvironment and hopefully transition these patients from non-responders to responders, Focus Ultrasound was a tool that presented great promise, and as Dr. Buckner was just talking about in terms of the alterations in the immune environment. So we're running a trial right now that's a pilot trial to evaluate Focus Ultrasound ablation with or without PD-1 blockade in patients with advanced solid tumors. And our goal is really just to ablate a part of the tumor. So our treatment sessions are really well tolerated and quite short because we are ablating about 33% of our tumors. And so it's been great. We've had trouble with enrollment, but we have treated 4 patients so far with metastatic colon, gastric, thyroid cancer, and melanoma. 2 of these were on the arm of Focus Ultrasound alone, and 2 we combined with PD-1 blockade. So I'm looking forward to this conversation with these colleagues.
Thank you very much. Now we'll move on to Dr. Erin Kim. Erin?
Thanks, Karun, and thanks to the organizers for this. And I'm excited to talk about this session and the work with soft tissue sarcomas and soft tissue tumors. I originally got into Focus Ultrasound primarily because it felt like it really aligned with what we want to do for pediatric cancers. So we know that in pediatric cancers, we've had a lot of successes. We cure many patients, but the success has not been equal among pediatric cancers. And the patients with relapse, recurrent, or metastatic soft tissue sarcomas and solid tumors have a dismal outcome. And we haven't made many strides over the past 30 or 40 years. And those that we do cure with aggressive therapies, including chemo, radiation, surgery, have a lot of late effects. And so the goals, in terms of early phase and thinking about novel therapeutics for pediatric cancer really align with the goals of Focus Ultrasound. We want to get better therapies with less toxicity. So when it was initially introduced, I'm like, wow, this technology, there's no radiation, there's no surgeries, this can maybe replace all of our local control for pediatric cancers. And so we first started with this trial thinking about ablation therapy for children with relapsed recurrent solid tumors, including desmoid tumors. And that that trial was recently completed, and we learned a lot in terms of the limitations and applicability of ablation therapy for pediatric solid tumors, and ways to enhance that effect, thinking about combinatorial approaches, because when we think about solid tumors and malignancies, the goals of local control really have to be getting at the entire tumor and thinking about sarcoma-like margins. And so one of the ways we thought about mitigating that is combining focused ultrasound with thermosensitive liposomal doxorubicin to target more of the tumor. And we're looking at the next iteration of this trial, looking at combination with hypothermia. And so some of the challenges that I think we'll be discussing today, and that I'm excited to talk with the colleagues here, is challenges in terms of the inabilities to complete ablation with some of the ablative technologies, some lesions that are actually not targetable with the HIFU technology at this moment. And I think of pediatric malignancies, in particularly, even though they're solid tumors, they're still systemic diseases, and how we think about metastatic lesions. So I'm excited to think about future applications that have been discussed for other tumors here, as well as other applications for non-tumors that can be applied to our sarcomas and solid tumors, including combinatorial approaches, immunotherapy, and other mechanisms such as radiation therapy.
Great. Thank you very much, Arang. And last but not least, we have Paige.
Thanks, Karun, and thanks everybody for attending, and hopefully we have an interesting conversation about some of these challenges. On the left there, you'll see Dr. Dukes' work. Dr. Dukes was a visiting scholar at Stanford. He's amalgamated the results of our experience as well as that of Dr. Buckner and that of Dr. de Bratwer in Melbourne with 105 patients with desmoid tumors. There's an example of a success there, a guy with a recurrent desmoid tumor in the right buttock that we treated over multiple ablation sessions and were able to successfully eradicate the tumor and avoid any significant side effects. That being said, we have largely stopped doing focused ultrasound for desmoid tumors at Stanford, and we've largely replaced it with MR-guided cryoablation. And that's what that middle panel shows. This was a patient actually that had a portion of a deltoid desmoid tumor treated with focused ultrasound. You can see the results of the post-focused ultrasound ablation on the top left panel. You can see that there's residual enhancement along the superior aspect, which is not uncommon to have residual tumor. This tumor is very close to the skin, and I think it was frankly a tour de force to be able to ablate that much of the tumor without causing a skin burn. But in any case, it was close to nerves, close to skin, and there was some residual. You can see in a short follow-up of about, I think, 3 to 6 months after, on the top right image, you can see how much growth there has been of the residual tumor, occupying again much of that right deltoid region. In the bottom left panel is an MR image during our cryoablation. Multiple needles are placed. You can see the ice wall forming. And you can see some of the advantages of cryoablation here. The bright signal that you're seeing between the skin and the needles and along the surface of the tumor is hydrodissection. So we're able to basically peel the tumor away from the skin by injecting a bunch of warm water underneath the skin and thereby protect the skin. You can protect nerves, et cetera. That's not something that we can do with focused ultrasound. And then on the bottom right image, you can see the results now 2 years post-cryoablation, so very effective results. The challenges that we have faced are surmountable, but they have, and some of them have been addressed, but some of them I think remain to be addressed. So positioning. We have an in-table transducer. That is the wrong device for musculoskeletal applications. It is very hard to position a tumor in the palm of the hand or the back of the ankle on top of a table that's designed for a woman to lie flat and have her fibroids treated. So that's a major thing. It takes a lot of time to position patients and a lot of variability in how we have to work to position patients for these treatments. Skin and nerve protection. We lack skin protection in the kind of vendor-provided device. Thankfully, Allison Payne at the University of Utah, and in collaboration with us and funded by the Focused Ultrasound Foundation, has built a skin cooling system that we can integrate with that device. That's helped us to expand a little bit in terms of who we can treat with desmoid tumors. We actually use it for all of our applications now, fibroid, bone, everything. And it should be something that's really built into this, to the system, frankly, as it is into the brain and prostate systems. But even with that, we still don't have a way to protect nerves other than to avoid them. So we don't have the ability to hydrodissect them away. So that's, again, a limitation. Size limitations, we've learned not to treat big fibroids in one session. And the reason for that is because of unreliable thermometry. Each sonication gives you thermal dose, but it doesn't account for tissue that did not reach thermal dose during that sonication, but was warmed. And the assumption is that by the next sonication, that tissue's gone back to 37 degrees. It hasn't. And if you sonicate 100 times, that tissue that got to sublesional dose on any individual sonication will eventually reach thermal dose. But it's not captured by the system, which means that you don't know actually what's going on with all the tissue that you've been trying to sonicate. And we learned the hard way that you actually accumulate a lot of dose in the near field, which can lead to areas of the tumor that you didn't directly ablate being ablated, but it also means that the skin in the near field can be damaged. As well. We've talked about this. There's a paper by Rochelle Baton that talks about long-term thermometry as a way to address this problem, but it's not integrated into the system. It's something that we had to plug into the scanner ourselves and pull off the thermometry images ourselves and try to analyze them as well. Again, surmountable, but not integrated. And finally, the technical parameters. The parameters that the system puts out are designed to treat fibroids. We have to sit there and manually adjust every single sonication spot based on angle, based on power, duration, et cetera, trying to account for how heterogeneous the tissue is. If you don't do this, you end up with either ineffective or over-treatment as well, how do you address this? Well, one, you could have smarter treatment planning software, right, that takes into account the experience that we've had treating these very heterogeneous tumors. And this really stretches across all soft tissue tumors. You can look at T2 signal, diffusion signal, perfusion signal, and come up with a much smarter software to begin with, or you can power modulate. You can take the real-time thermal data that you're getting and modulate the power that you're putting in, as is done, for example, in one of the systems for prostate. All that being said, I think Matt really summarized it nicely. You know, we have a lot of confidence when we treat a small bone tumor, right? And we need that same level of confidence when we want to treat these soft tissue tumors. Otherwise, we're going to look for alternatives where I don't have some of these challenges. Cryo is an example for that. Again, some of these things are surmountable. I gave examples of how we've kind of done some homegrown solutions working with colleagues. I'll give another example there. There's a paper that recently came out from actually one of the world leaders in cryoablation. Afshin Ganji was a participant in this paper, where they built their own HIFU system designed to overcome some of the challenges of patient positioning and design and so forth. And there's a publication there that you can reference for that. So again, the field is transitioning. We've hit kind of a roadblock. We've surmounted some of the challenges and found ways to get around some of the others, but I think integrating all of that into a future system needs to happen before we can really do this robustly for some of our soft tissue tumors.
Great. Thank you very much, Paige, for that comprehensive look at soft tissue tumors and desmoids and how to overcome some of the challenges we currently have. We're going to move on to sort of the next portion of the talk, and this is questions that all four of the panelists talked about and discussed in advance, and we think are important to discuss here. I'll also encourage the audience to come up and ask any questions or put them through the app as well. But the first question, and some of these I might want to ask specific people too, but we covered a lot about how to address the limitations using ablation alone. But we certainly, there's the equipment limitations, and then there are the inherent tumor limitations. And you guys touched on heterogeneity a little bit. Vascularity would be another one. The thyroid example with macrocalcification in the middle. Do you think that what we have learned so far with histotripsy or with hyperthermia can be used to address some of these limitations? Matt, what do you think?
You mean whether or not we can just use the early data we've gotten from some of those studies to address the limitations in terms of heterogeneity?
Yeah, I was thinking specifically about, for example, in desmoids, the T2 dark areas versus the perfused areas and so on, and how they respond differently to heat accumulation. whether something that's more mechanical and less based on heat could improve our ability to treat that heterogeneity a little bit better.
Yeah, I think for sure there's a lot of promise into looking at these different mechanisms of action and doing robust basic science studies to get a sense of, what are the different effects across different tumor types when we approach these soft tissue tumors in different ways. But I think it really requires a much more exhaustive and organized approach than we've been able to manage so far, just because there's so many different kinds of tumors, and each of those tumors can have so many different imaging characteristics, which likely have different responses to the different mechanisms of action. So, right, you end up with a really exponential number of possibilities very quickly. And I think the only great way to handle that is by having a fairly exhaustive research approach.
Yeah, especially with your experience with sarcomas and all the heterogeneity there, I can understand that.
I would add that, I don't think histotripsy necessarily is going to be a cure-all here, in that, if you look at just in the liver, the parameters for treating HCC are not the ones that are going to be used for cholangiocarcinoma. So you're going to have the same issues with soft tissue tumors. You're going to have to define the parameters for treatment, whether it's FUS or histotripsy.
Completely agreed,
Yeah.
yes. So Lynn, you're taking us out of the MSK system a little bit with breast and, melanoma and metastatic thyroid and colon. And you also use a different platform. I think we're using the Sonaleave, which is MR-guided, and Paige and Matt are using the InsightTech, which is MR-guided, but you're using the Therapies, which is ultrasound-guided. Can you tell us a little bit about your approach to in your trial, and also the rationale for ablating a third of the tumor versus 2/3 of the tumor, or complete ablation, please?
Absolutely. So first of all, with the approach of using the ultrasound guided system, of course, that has some limitations in terms of where we can access in the body, and the system itself has fairly specific limitations. You have to be deeper than 5 millimeters from the skin, and you can't be more than 23 millimeters. So there are some technical limitations from that, but for the trial that we proposed, the tumors all just have to be within that range. And so as I mentioned, the goal is really not to ablate the whole tumor. In fact, when the research has shown that the area that's completely ablated is not as immunogenic, and we do not want to denature the proteins. We don't want that complete necrotic center zone. So when you look at the areas of ablation, there's the secondary or periphery zone, which is more immunogenic. And so we designed our protocol to skip areas within the tumor, hopefully mimicking the preclinical work showing this secondary periphery zone. And so by skipping around the tumor, we're hoping to cause the more focal necrosis in limited areas, but then create an immunogenic sort of peel around that core.
Great. That actually takes us into several conversations that Erin and I have had over the years about whether fundamentally the approach to something that might be benign, like an osteodystioma, or locally aggressive, but challenging locally aggressive, like a desmoid, and ablating those is one thing. But if we're talking about malignant tumors, and this is, I think, what you're working with, and trying to combine things beyond ablation. So Erin, can you talk a little bit more about your perspectives from the oncology side about what you think the limitations, now that we've treated a lot of patients with this, are to ablation, and your specific approaches that you alluded to earlier about combining with the drug delivery and looking for immune readouts?
Yeah, so I think, in addition to the tumor heterogeneity in itself, so not just the tumor itself, but how a lot of these tumors present in terms of the way they look. They're not these nice oval-shaped tumors. They are large, they're infiltrated, and their location, like we're talking I treat everything neck down. So we're talking, it can be located anywhere in your body. So it can be extremity, it could be liver, it could be kidney, gut. So all that heterogeneity, including the equipment limitations, I think make treating these solid tumors very challenging. And so when we think about our original ablation study, just looking at using FUS for ablation, you know, the one patient where we were able to get complete control was a small tumor that was about 2.5 centimeters in size and very easily approachable, similar to how I think osteoid osteomas are, where you can approach them because they're smaller and they're able to be completely ablated, which is what I feel like we need to do for our malignant tumors. Like we can't, if we're using ablation alone as the kind of the way to treat them. So I really think, you know, work that Lynn's doing, other folks are doing in terms of how do we use some of the mechanisms or to mitigate or to adjunct in terms of the therapies with focused ultrasound. So I think thinking about enhancing drug delivery, thinking about combining with immunotherapy. Maybe we only need to do a small area, as Lynn had suggested, and then treating that to create an immune response. I think that's what we need to think about for many of our malignant tumors, because just like ablation alone, you know, using it for like other ablative technologies is not going to cure someone with metastatic malignant solid tumor. We have to think about other mechanisms that can be added. And I think focused ultrasound has the opportunity in many of its different mechanisms to be able to do that in a combinatorial approach.
Thank you. Thank you. Paige, your thoughts on the combination therapies in the field of malignant lesions?
We tried to treat sarcomas with focused ultrasound as part of a clinical trial several years ago, and it's how we got into soft tissue tumors. And I think some of the same challenges I described before quickly led us to realize the limitations. That was a treat and resect study, and so we could, the goal was to treat just a portion of the tumor and then resect it and compare histology to imaging. That's as easy as it gets, frankly, right? You can find the pre-selected tumors, find the part of the tumor that's as far away from nerves and bone and skin and so forth, and just treat that part. And even with that, we found that it was very unreliable about the imaging. You know, if you had a far field effect, if you hit the bone and the tumor was near the bone, you would heat up the bone and that would heat up the tumor. And again, parts of the tumor that you hadn't directly treated ended up being ablated. And it wasn't being predicted necessarily by what we were seeing, which meant that if you were imagining down the road that you were going to be doing this in lieu of surgery, you want to have absolute confidence, as we were saying earlier, in our thermometry and in our thermal dose, and we weren't able to achieve that. And it's one reason why we pivoted to desmoid tumors, where it wasn't necessarily the case that we had to kill all the tumor. We could just do tumor control. Certainly for the case where someone already has metastatic disease, you have to consider these other options, you know, activating the immune system, et cetera. But as we talked about a little bit yesterday as well, I think if you're talking about a malignancy that is localized still, but has malignant potential, to some extent the reason that we're thinking about these other options in that context is because the ablation device and approach is not yet sufficient. But I think that's just a challenge that needs to be overcome. I think there is the possibility that we can eventually develop these technologies to the point where you could confidently treat that malignancy before it's metastasized. We're just not there yet, and in part it's because of some of the challenges we talked about.
Okay, agreed. And then one more question for both Matt and Lynn. I know it's early and the data may be limited, but what sort of things are you seeing in your immune readouts? And what are you thinking that you might see in your immune readouts?
Yeah, I think it's a little early for us. We don't have a ton of data to make a lot of conclusions for, in terms of we've just treated a few patients in this ongoing trial. But I think we were really excited by some of the data that showed that undifferentiated pleomorphic sarcomas did seem to have some responses in limited clinical trials to various checkpoint inhibitors. And so we're hoping that we can, you know, in a synergistic fashion, combine focused ultrasound down the road with those checkpoint inhibitors in order to improve treatment responses. I think that when we're talking about and thinking about the different ways in which we want to combine focused ultrasound with other modalities, you know, you can think about certain situations in which focused ultrasound remains as the primary treatment modality, that is, you know, with the intent to completely ablate the tumor predominantly with focused ultrasound. But I really have a lot of hope in the kinds of studies that Lynn and I are doing, which maybe down the road, even in patients who only have resectable disease, that if you were to do a limited focus ultrasound treatment of those patients before they go on to resection, you might be able to improve their long-term outcomes down the road, even though you're not completely ablating the tumor with focus ultrasound. So I feel like it really just the entire field really speaks to, or the possibilities of these synergistic actions speak to the need for having more robust studies that start to organize in a collective manner the different ways that we can think about combinatorial approaches. But love to hear what Lynn thinks as well. Oh, I think you're muted.
Thank you so much. Yeah, that was great. I wish I could say that we have data to support the hopes that you and I have, but ours is still early too, so we haven't yet interrogated our samples. We've treated 4 patients, so it'll be a bit of time before we do that. Obviously, safety is our number one endpoint given the equipment and experimental use of it, but we're also looking at the CD8 increase in the treated environment and hoping to see at least a 2-fold increase in CD8 penetration in the treated lesions. And then for patients who have untreated lesions who are consenting and agreeable to biopsy, which we've actually had 2 patients do, which is quite kind, we'll also look at off-target lesions to see if we have any distant effect, which would, of course, be a huge win from an immune standpoint. But we don't have data yet to tell us whether that hypothesis or hope is true.
No, thank you very much. Looking forward to that data. That will help inform a lot of subsequent studies, I think, for us too. The next question, we really, I'll mainly ask Paige and Matt to talk about, I think, because at least at our place, everything is being performed under clinical trials, and therefore the funding comes from there. We haven't really had the need yet to seek reimbursement, but I think we're heading there. And you guys have had that opportunity. You've kind of gone beyond that and are getting reimbursed for some treatment. So could you talk a little bit about your experience with getting reimbursed by the insurance companies?
Matt, you want to go first?
Yeah, sure, happy to. I feel like recently it's been a really positive experience. It feels strange to say, and I'm a little nervous about jinxing myself by saying that out loud, but it really does. And I don't know, we went through a change probably about 1.5 years or 2 years ago, where we moved our focused ultrasound device from essentially a freestanding outpatient imaging center to a hospital location. We're able to provide much better support for these treatments. And during that process, I think that there were some changes in how our billing department was approaching billing. I know that I just checked in with our billing department. We predominantly use this code, this 76498 code for unlisted magnet resonance procedures, and we really have had a lot of success. I can only think of one patient that had an initial denial in the last few years when we're trying to collect reimbursement for desmoid tumors, and ultimately that patient continued to appeal. She actually got treated, believing it was the best thing for her care, despite the fact that the insurance had said no as their final answer, and she appealed to a California state board, and they ended up overturning the insurance's denial, and she was able to get we were able to get reimbursement. So we've had a lot of success, but I feel like it's a little bit of magic. I don't know exactly when it's going to happen, or what's going to, maybe if it'll dry up at some point in the near future. Hopefully not.
Knock wood, man. I share your pain. And I wrote down your code, by the way. So insurance is a big part of the problem. If you think about desmoid tumors, for example, they often need to be retreated. And we go into it often with a plan for a staged procedure. Some of the results that Daniel will present or has demonstrated are in part, or are actually not in part, are significantly impacted by the fact that it's very hard to get the initial approval, and it's just as hard to get another approval for the follow-on case. It's not like you get approvals for multiple sessions up front. And as a result, what you're often seeing is just the impact of having one shot at it, which sometimes means you maybe try to bite off more than you can chew, or you go into it knowing it's just going to be a tumor control case and you wish you could bring the patient back again. That is one thing that's impacted our decision to switch to cryo, is that when we seek authorization for cryo, it's much more straightforward, it's much more likely to be authorized, and it's much more likely to be reauthorized. So we know that we want to do multiple sessions, we can plan that and get that approval up front. So it is a big part of this problem, actually. And I will say that on the plus side, it's whether for desmoids or osteomas, it's been relatively easy to get authorization for children. But for those same applications for adults, it's definitely an uphill battle. Part of it is familiarity. I think most of these medical directors that we end up talking to in a peer-to-peer know what cryoablation is. Very few of them know what focused ultrasound is.
That's a very good point. Okay. Lynn, I assume that most of your work is through clinical trials and funded. Do you have any experience with reimbursement in the breast or for melanoma?
Sorry, I don't have that. All of our work has been funded by clinical trials.
Okay, that's where we are too. Okay, just watching for time. Are there any questions from the audience? We have one from the online. It says that since it's difficult to position the hand or foot for proper tumor ablation, has there been any talk about developing a novel transducer design specific to these applications? What do you think, Paige?
Right, so you could take the approach of designing something specifically for these different limbs, or you could design something that could accommodate independent of patient position or tumor location. The closest thing that we have is the former approach, right? Is something that is maybe more specific for certain locations. And what you could use, for example, is something akin to the conformal bone system, which is something tethered to the table rather than built, where the transducer is tethered to the table rather than built into to the table. And then it's just a matter of positioning the transducer over the area that you're trying to treat. I think that that Cabras paper that I mentioned earlier has kind of taken that idea, and their transducer is something that I guess has some robotic control and so forth for positioning as well. And so yes, you could design transducers that are better suited to musculoskeletal applications.
Yeah, or maybe even couple the idea of what Dr. Ganji's paper was showing with the same, well, first of all, get it out of the table, but secondly, on a robotic arm, and then thirdly, have it be able to mount different transducers for different applications. So,
good point.
Yeah.
I know for our trials, like we have been very creative in positioning these patients onto the table. Mm-hmm. All of our patients have undergone these therapies under general anesthesia, so it is a little bit easier to manipulate some of but it was a lot of work figuring out these things and prepping the patients in order for the positioning. So if there were ways that companies can modulate the systems to make that easier in terms of applicability, it would be helpful, I think, for our patient population.
Yeah, we often spend hours with a patient under general anesthesia trying to position them appropriately. It's not just a matter of getting them on top of the transducer, it's getting them there, and then they have to stay there for hours, and you want to make sure that every pressure point is cushioned so that when they wake up, they don't have skin breakdown or nerve palsy. Yep. Having gone through all of that, we've learned the hard way how to adjust for all of these things, but it is extremely time-consuming to figure out how to contort patients for this.
And allow for good coupling.
And allow for good coupling and have them wake up. Because honestly, you can have a great tumor treatment, but if they wake up and their foot is numb because of a pressure point, it's a bad treatment.
Yeah. Okay.
Dr. Dukes.
I have a question.
How do you cope with soft tissue behind tumors like a desmoid, which is a very big tumor? We know from the clinical experience, if we do this in the 3-4 session, but how do you cope with these patients when you How do you cope with these patients when you do the planning? Because reimbursement is a major problem. I know that you take time for 4 or 5 hours treating a patient in an anesthesial setting, which we don't have in Germany because we are much less reimbursed. So we can treat a patient for 3 hours maximum, then we have to think about another treatment. And our experience with these large soft tissue tumors is that we can really cope with those tumors if you do this treatment in a multi-step procedure. Let's say have planning this from the very beginning with 3-4 treatment sessions in a kind of period to come back for the patient. And the problem is reimbursement on the one hand, but how do you talk this with the patients? I mean, this is a problem. You can achieve a lot, but we cannot do this. And this is a problem which I face a lot.
Pat, do you want to talk about this, or?
Yeah, sure, I'm happy to, thanks. I think that it depends a little bit on the goals of treatment for any individual patient, which is going to be determined by where their tumor is and how much of it can be ablated and what their symptoms are related to the tumor. In general, I'm trying to ablate as much as I possibly can within the time frame I have available to me. I understand at different centers that's going to be different. I'm very fortunate that I can go out 5 or 6 hours if I need to, but I feel those time pressures too. People are not happy when I am using the scanner for that duration of period of time. But I think patients, a lot of the patients that are coming to us with these soft tissue tumors and don't have many other options are often grateful for any sort of coordinated approach that is addressing their fundamental needs. So just in terms of centering what are the patient's goals of care and then designing a treatment plan that works for those, it varies from patient to patient, but as long as you put patients at the center, it seems to work out okay.
I would echo that, Dr. Dukes, that often these patients don't have other alternatives, or if they do, they don't want to pursue them. And so they're part of the partnership both in getting authorization. They're often involved in appeals all the way up to the state government level to try to get approval, even for that initial treatment. And we go into it knowing we're basically trying to shoot for tumor control. We do have, I guess, the luxury of being able to treat longer than 3 hours, so we try to treat as much as we can in that time, keeping in mind what I said earlier about this knowledge that we've gained about accumulated dose. You don't want to overdo it either, because that can lead to complications. And so the patient realizes that they're going to get some benefit, and we tell them that in our experience, even if a partial ablation that, let's say, crosses a 50% boundary or so, is likely to result in some pain relief, some improvement in range of motion, for example, but that the likelihood is that the tumor will eventually recur and they will need some other treatment at that point.
Yeah, and our experience is the same, with the caveat that we put a safety upper limit on anesthesia for pediatric patients at 4 hours. We don't feel the pressure because our MRI for HIFU is usually available, but the anesthesia is a concern. And when we first see the patients and evaluate them for larger desmoids, we pretty much tell them that this is going to probably take more than one session and make a best guess as to whether it's 2 or 3. Yeah. Okay, well, that's on time. Thank you, everyone. Thank you for your participation. And thank you, audience, for attending. Have a good lunch.
Thanks, everyone. Our next panel is going to be around 2:20, but I would encourage you to grab a box lunch. There's some in the hallway here, as well as the large lunchroom. But grab a box lunch, come back in, and listen to our young investigators present the status of their work. So thank you.